All right, a warm welcome to you from Geneva, Switzerland. I'm Reda Sadki from the Geneva Learning Foundation, and I'm here with Charlotte Mbou. Charlotte, how are you doing? We're less than 2 minutes away from starting this Teach to Reach 11 session.
Doing great, Reda, and looking forward to listening to the collaborative members.
Indeed. So this is 4 months on. We're going to tell you this, and actually they're going to tell you this remarkable story of how Nigerian health workers across Nigeria, every state, over 300 local government areas came together for immunization to make vaccines work and to protect the children and families of Nigeria. We're less than 1 minute away from getting started. If you're joining us on the YouTube or LinkedIn or X or Facebook, you're welcome to share your comments. We won't be able to invite you to speak. You have to be at the conference, at the Teach to Reach 11 conference to do that. You have 35 seconds to get there. Let me show you what it looks like. So this is a brand new conference platform for Teach to Reach. And you can see there are sessions on Nigeria, but also on malaria, climate, health risks and barriers, and then there are opportunities really to meet, network, and learn with fellow health workers from all over the world. All right, 13 seconds. You can count down with me, and here we go. On the 7th of March 2022, the Geneva Learning Foundation, working with partners from all over the world, launched a call to join the Movement for Immunization Agenda 2030, responding to a call from the Director General of the World Health Organization, who called for a groundswell of support for immunization. Now, 3 years on, at Teach to Reach 10, we have held a number of sessions, including the one at Teach to Reach 10, of this Movement for Immunization Agenda 2030, really hearing the voices and the actions of IA 2030, Immunization Agenda 2030 leaders, implementing case studies, implementing concrete practical actions. We've also shared the not just the voices, but also the faces of immunization by inviting you to share photos documenting the daily work that you do to make vaccines work. You can see the two collections that have been issued at the Geneva Learning Foundation. And throughout this period, Teach to Reach has been a milestone for immunization staff all over the world participating in this movement. For example, at Teach to Reach 10, we also announced the launch of HPV vaccination health worker experiences and tips from the front line. What actually works? How do people in countries who are tasked with making HPV vaccination work do it? At Teach to Reach also, we had many contributions, including those from women, mothers, professionals, humanitarians, health professionals, to the Women Inspiring Women collection, so a remarkable collection of stories of women addressing their daughters or other young women aspiring to careers in health or humanitarian work. And then it was at Teach to Reach in June that we actually had this remarkable session, Humanly Possible, celebrating 50 years of the expanded program on immunization. Now at Teach to Reach 10, we did celebrate immunization globally, but there was one special moment, and that was when we announced the launch of the Immunization Collaborative. And this is a partnership with NPHCDA, with UNICEF, with the Geneva Learning Foundation, with Gavi, but you'll see that was just the start. There are now over 600 organizations that have joined the collaborative. We launched the collaborative and in July carried out the first peer learning exercise. I'm going to ask Charlotte to read the first of several testimonials that we heard at the end of the first peer learning exercise after just the first 3 weeks of the collaborative.
Challenges we face in our communities are not limited to us alone. Many face similar and even more challenging issues. Issues seem to be simple, but they are interwoven. A solution requires multiple approaches. Root causes often have systemic issues that need to be addressed in order to be solved. I learned how to do a root cause analysis. I realized that vaccine hesitancy is not the only reason for missed vaccination.
Thank you, Charlotte. And this is why we're now gathered today at Teach to Reach 11 in order to actually hear from leaders, health leaders from Nigeria, from the collaborative, from the movement for Immunization Agenda 2030 in Nigeria to tell us what did you learn about your own capacity to make a difference through these first activities, the first set of activities launched by the collaborative in Nigeria. So we have with us in the studio, we have a number of health leaders from the collaborative. We have, of course, Nigerian health workers, but also supporters, fellow health workers from other countries. We're going to ask you to raise your hand if you participated in the collaborative and would like to share what did you learn about your own capacity to make a difference by engaging in this way. So we're going to go to Usman Mohammed Tukur. Usman. Yes, we're having trouble hearing you, Usman. Let's go to Bello Haruna, and then also to Fani Ogu. All right, Usman Mohammed, your microphone is unmuted, but we're not hearing you. And this will happen throughout. I've said this. I said this in the morning sessions for Teach to Reach 11. Yes, Fani, are you able to speak to us? All right, we'll keep trying this. This is normal. There are real connectivity challenges, in particular in West Africa right now. So, if you are a member of the collaborative, would like to answer, are able to answer this question, please. Fanny, we know you were able to speak to us earlier. Let's go also to Adam Suleiman Abubakar, Adedamola Odutayo, Adebayo Ikundayo. The floor is yours. We're still trying to get Fanny on the line and to hear some of these remarkable stories from the collaborative. Let's go. All right, because of these connectivity challenges, and they can be quite severe in some cases, let me show you. We asked this question as part of the Teach to Reach questions, so please do raise your hand if you're ready to speak. We'll keep trying to, we'll keep calling for speakers. Want to share with you what Nigerian health workers have told us. You heard a few of the testimonials read by Charlotte initially. Here is one from an anonymous medical laboratory technician who says, I now believe I can help my community with my skills in medical laboratory science without having to change my profession to public health science. All right, let's try Fanny Ogu again. Fanny, are you there now? Are you able to speak to us? I see your hand is raised. All right, Fanny's still having connectivity problems. If you participated in the collaborative, of course, then this question is specifically for you. And we're trying again, Bello Haruna, Adedamola, and Adebayo, who all have their microphones activated and seem to be ready to speak, but are not in practice. All right, we're going to look at a second set of insights. Second insight from this one is from Uyebi Enosandra, who's a disability specialist in an NGO in a health facility. And this is what she told us she gained from the collaborative. And it's true, the first peer learning exercise was in fact focused on root cause analysis. Charlotte, can you tell us a little bit about what Nigerian participants, Nigerian health professionals who joined the collaborative and helped to create and lift it were able to do in that peer learning exercise focusing on root cause analysis?
Yes, Reda, and I just wanted to indicate that Uyebi Enosandra is actually with us in the room. So maybe after I share, we might turn to her to tell us a little bit more about what she shared and what she gained from participating in the collaborative. So this was really about engaging health workers from Nigeria, working across different health system levels, across different organizations, whether they be a local organization, community-based organization, civil society organizations, NGOs, government. They all came together and what they were sharing was they were facing challenges with reaching their communities with immunization services. And so together in the peer learning exercise, they wanted to go to the root cause, to the very root of the problem that they were facing. And one thing that stood out, apart from a few of the comments that I read at the beginning, Reda, was the fact that a lot of them were surprised to discover that the initial cause, the thought was the reason why they were facing that particular challenge was totally different from what they found out after applying the 5 Why principle.
Thanks, Charlotte. All right, let's try now to go to Sandra. I heard static on her line. Sandra, are you able to speak to us? I hope you've managed to get your connectivity and equipment working.
Yeah. Can you hear me?
Yes, loud and clear now. So you shared, you told us root cause analysis technique has helped me improve in my work. Can you tell us a little bit about the work you do for immunization in Oak Bay local government in Delta State? And it's particular because the work you do is as a disability specialist. So we're very interested in hearing what your experience of the collaborative was and what did you learn about your own capacity to make a difference?
Good evening. I'm speaking right here from Bangkok, and time difference is good evening here to everyone in the room there. It was a very interesting journey. The root cause analysis really opened my eyes to so many things. Just like what Charlotte said, initially we were just seeing it from one side of the whole issue. We were just seeing it as if everything was just based on community members discriminating against parents with children with disability and all that. But when we apply the root cause analysis, the 5 Whys, this opened our eyes to see that it was not all about community members alone. It was also, we also have challenges with the health worker, the primary health workers, not knowing how to, incorporate children with disability in the immunization program. We are attached to a primary health center in Oak Bay local government from a project we are running now with a global fund. They implemented through ICOMI. And so the project is all about malaria, immunization, and nutrition. Also tuberculosis and then HIV/AIDS. So I want to speak using the disability lens to see, to tell you how the 5 Whys help us. Before then, we are just, angry with how people were giving negative attitude to parents with children with disability, not wanting to associate, not wanting to carry them along. Even during the campaign of the immunization, they wouldn't want to even call them to be part of the process. But later on, we find out that it was not all about the community members, their negative attitude towards this family with persons with disability or children with disability. It was also about how the staffs in the PHC was not able to undo persons with disability appropriately, or children with disability, incorporate them into the project. They don't know the know-how. It was when we applied the 5 Whys that we came to know that, it's not all about the community members. It's also this kind of capacity gap on the side of the health workers on how to incorporate children with disability into the program. And so now we're able to say, okay, we've come to know this. I think the health workers need to be trained on how to handle children with disability during this campaign. And also we have to take advocacy down to the appropriate authority like the government side, because of not, sometimes making budgets for training for this health staff. So with this, we are so happy, and now we don't trade blames now. we are trying to see with the results, finding out the real root cause of everything. We can advocate for government to make provision for constant training of the primary health center, to make their training inclusive, to make them know how to handle children with disability during immunization campaign. That is the stage that we are now. And also, we've been able to, carry our sensitization to the community people, trying to make them know that disability is not a disease, because that is one perception they have, that if you get closer to a family with persons with disability, it might transfer to your own family when they start having children. So they try to avoid them. We also carry this campaign to the community level, telling them disability is not a transferable, it's not even a disease. It could be caused by disease. You can have disability, but it's not transferable. So they shouldn't be seeing them like that.
Sandra,
So
just so we can understand correctly. So, was your challenge to figure out how to make sure that the children with disabilities are included in routine immunization, or is it that you took the root cause analysis you did for immunization and you transferred it, you used it in a different with a different challenge around disability?
I think it's both. It's both. Children with disability was totally excluded in my community, and with the root cause analysis, we were able to know that the staff never had the knowledge of how to immunize children with disability, because they said the side effect of the immunization might be very serious and they'll be held responsible. So they don't even want to involve. They don't want to involve. They don't want to even encourage them. They just, even when they get to the community, they know. They'll see a family with a child with, for example, physical impairment that is so severe. They just walk past. They wouldn't want to even give that child that immunization. That was the problem we had. But with applying the 5 whys, we later discovered that it's because they don't have the knowledge, the know-how on how to handle these children. So that was one good thing we gained from the
thank you, Sandra. So I have another question for you. Can you tell me, was there anything different about the collaborative from everything else you have done before?
Yeah, before we don't really know how to go about solving our problem easily. We just brainstorm, moving from here, they're thinking different ways. But with the 5 whys principle, makes it so easy. When the issue comes up, we say, okay, let's go. Let's use the 5 whys. Why is this issue? Why and why till we get to the final root cause.
So Sandra, you have a question from Saidu Yabagi, who I believe is joining Teach to Reach for the very first time. And he says, please, can someone tell me what these 5 whys are? So can you sum up what is this 5 whys technique that gets you to a root cause?
The 5 whys technique is a technique that when you identify an issue, you ask why. And the first why you will ask will give you an answer that will make you ask another why. And you keep asking the why, even sometimes it's more than 5 whys. But with the 5 whys, the common 5 whys, before you get to the 5 whys, you get the real cause of what is the real problem that is that the issue is all about. And with that, you'll be able to get the root cause of the problem, which makes it easier to have solution to it.
Mm-hmm. Wonderful. And I'm going to show another. This is from Miss Suleiman Habiba Gambo from Kabbalah Ward in Kaduna. So she's a health practitioner who works at the district level for the Ministry of Health. And when we asked her 4 months on, what difference has your participation in the collaborative made for you? She said, I met Dr. Mansour Abdu, a data science expert, and received personalized guidance and improved data analysis skills. And she said she was struggling to improve her data analysis skills. So Sandra, my question for you is the following. Did you make any connections during the collaborative that have helped you in any way, similar to what Ms. Suleiman Habiba Gambo shared with us?
Yes, I met a few friends in the NGO setting, because I'm coming from the NGO setting. I met few friends that we presently work together. I've been calling them. If I have any challenge, I call them, and we put our heads together and come out with accurate solution on whatever we raise.
Okay, wonderful. All right, and then we're going to tell the story of the collaborative for those who are discovering it today. I see Bello Haruna, you have your microphone active. Are you able to speak to us? Bello Haruna, are you able to speak to us? No. So, all right, let's keep going. Then we're going to tell you the story about what. First of all, what is this Nigeria collaborative about? And many children in Nigeria do not receive all the vaccines that they need. Every year, 4 million children miss out on vaccination. That's the historical numbers. And the idea, the value proposition was that as health workers, Nigerian professionals can come together to help the country do better. Now, this was the Geneva Learning Foundation that organized the peer learning exercise, but it was really in support of the Nigeria Movement for Immunization Agenda 2030, working with NPHCDA, UNICEF, as well as Gavi. So when we did the first peer learning exercise, we really demonstrated the potential for large-scale digital peer learning to address local challenges. But the remarkable thing was who joined this collaborative. And first of all, within 2 weeks, we had reached countrywide more than 4,000. It's now over close to 5,000 health professionals connected from all 36 states, plus the FCT, more than 300 local government areas. So all 36 states, you can see the distribution here. And that was really the first remarkable achievement, was being able to reach this many people from a cross-section of health systems level and close to gender parity. What was even more remarkable is not only individuals joined, but also 628 local organizations joined, bringing their organizations, their support to support health workers making connections with each other. We asked you, of course, what are the top challenge categories? And adults and children missing their vaccinations, 42% said it was reaching zero-dose children and missed communities. And again, within the first 2 weeks, we had 2 volumes with hundreds of experiences shared by health professionals across Nigeria. And after 4 weeks, these are the numbers: 4,434 health workers from all 36 states, 628 organizations. And you heard Sandra discuss what she gained from root cause analysis. Over 400 root cause analyses were performed, peer-reviewed, and revised in just 10 days. So I'd like now to turn back to Sandra and to ask, really, what would you tell a close colleague, Sandra, about the learning experience you had in the collaborative?
Yeah, I'm even encouraging my colleagues to join. And the thing is that I don't really know when the next training will come on the root cause analysis, because they've been asking me, how do I join? When will this come and all that? And I keep telling them that the way it was a colleague that sent me the link, register, and then I find myself among the 400 that did that final analysis. Mm-hmm. So I told them I'll put my ears on the ground and I'll put my eyes on the platform to see whenever it comes up, I'm going to share. They are very much eager to learn about the root cause and the collaborative aspect.
All right, wonderful. Thank you, Sandra. Let's see what's happening in the chat. So several people have responded asking how to use the 5 whys technique. And Fanny Ogwu, we weren't able to get her to hear her voice this time, but she says the capacity to make a difference is the skill of RCA that I acquired, which has helped me to identify the root causes of various immunization service challenges. Also, I found out some challenges have many causes, but can be prioritized by in the order of relevance, feasibility, acceptance, and sustainability. That's amazing. Fanny, thank you. And the question we're asking now is what progress have you made in 4 months? So that is what we're asking today. And I don't know, Charlotte, if you've identified one of our guests of honor other than Sandra, who's ready to speak and doesn't have connectivity problems. We know that in West African countries right now, there are some, in some cases, in some locations, some pretty severe problems with connectivity. So we appreciate the efforts that participants are making to join today.
It's not really easy, Reda. So I don't know if Abubakar, okay, I see Abubakar is able to unmute. And I'm seeing, okay, Abubakar, are you able to speak? And yeah, I also recognize Gregory.
Yeah.
Yes.
Hello, good
Please.
day.
Yeah, good day.
My name is Mama.
Unfortunately, Reda, Abubakar seems to be having connectivity issues.
Yeah, it is the same
So I don't know,
problem.
Gregory.
Yeah.
Hello.
Abubakar, please, can you check your connectivity, and we'll definitely try to get back to you in a moment. So we'll listen to Gregory and then we'll come back to you.
Hello. Yeah, can you hear me? Hello?
Okay, yes. Yes,
Okay.
please go ahead. Mhm.
My name is Pharmacist Abubakar Osman Abubakar. So I am from Jigawa State. I work as a logistic and supply chain management advisor. So what I learned from my own capacity to make a different lines in leveraging a data-driven approaches and collaboration. That is by using an accurate data to achieve the measurable outcomes. So when I work for seasonal malaria chemo prevention project, I supported the training of community-based personnel. I ensure that efficient and distribution of malaria commodities and improved our reporting system. This experience taught me a lot of importance of teamwork, adaptability, and commitment to public health advocacy.
So Abubakar, sorry, I have to interrupt you. Are you referring to the Immunization Collaborative, or are you speaking about something you do in the context of malaria?
Hello, sir.
Yes. Are you referring to, is it that you took something from the Immunization Collaborative and used it for malaria, or are you referring to an experience you had focused on malaria? Because the malaria session is coming up next, so we will be asking you about that. But did you participate in the Immunization Collaborative in July 2024?
Yes. I said it's from the collaboration. I learned that about this the use of laborating data is very
Right.
important.
Okay, and then you were able to use that in the context of work you do around malaria. Is that correct?
Yes.
Okay. Yep. And so, with respect, can you tell us about the root cause analysis you developed? What was the challenge that you analyzed?
Okay. So the challenge I analyzed during my listening is that lack of reporting. There are some of the health workers, when they want to give their immunization, if some issues arise, they don't normally. I used to come and give a good report about the incidents that happened. So after I got that program, I will address the health workers about the importance of reporting whatever an incident. For example, during delivery of vaccine, some of the health workers, they are marker for marking the children that have been vaccinated. It's not working. There is no ink. So instead of them to report, they didn't. They keep administering the vaccine without marking the children that that receive and the vaccine. So this thing can make some children to get the vaccine and twice. So that's the route that I've discovered so far.
Okay, and so this was 4 months ago. What has changed since? What have you been able to do with this immunization work?
Yeah, so since we have so address and give them and the awareness that each ever an incident that happen, do not fear. Call your supervisor and let him know that so my vaccine, anything you can. So since then, we're having a very good data and very good reporting system.
Okay, and how have your colleagues and maybe if you're reporting data, you're passing up to the next level. How have they responded?
Yeah.
Did they have they been surprised by the improvements?
Yes, they are very, very supported, very, very supportive. Also because they even deliver a system that there's some hotline like phone numbers. Whenever you encounter an issue, you just call. As you call, your supervisor will call the head office. They will, if the address, if the sender need an urgent address, they are going to send somebody as backup and come and sort out the issue.
All right. Thank you very much, Abu Bakr, for this, for sharing what's happened with the root causes. And it sounds like we'd love to hear in the next session on malaria, we'd love to hear how you've been able to use root cause analysis in that other context. Let's try Gregory Agoko, Charlotte. And I did see Mario,
Yes.
who has an interest in Nigeria, did not participate in the collaborative unless I missed it. We'd love to hear if you're not from Nigeria and you'd like to ask questions of your colleagues, and of course that's very much what this session is about. Gregory, a warm welcome to you. Are you able to speak to us?
Yeah. Good afternoon, Reda. Yes, about 4 months ago we conducted the root cause analysis, and my focus was on children, zero-dose children in the IDP camp. As a background, I used to work in Borno State. About 3 years ago, I retired. I'm now living in Lagos. But by some form of coincidence, the National Primary Health Care, they had an outbreak response to which I volunteered and I was posted back to Borno. So I worked in the Jere local government where I used to work, and I could see that the issues have improved to an extent, but we still have situations where we could have zero-dose children. So I use this opportunity to try and conduct some trainings in collaboration with my colleagues who are still in service, and I think we were able to get good results during this time. And what I left behind from the trainings and everything, I think is a step forward. And I thank God for that. And it might interest you to know that the whole community in Borno was submerged underwater for some time due to a dam break.
Right.
So with that, we had multiple outbreaks. Our duty there was to administer the NOPV. That's the novel OPV type 2. But again, we had children that we had to administer OCV. That is the oral cholera vaccine, measles, and so on, because the situation of emergency was there. So I thank God that I was able to meet on the field many of my colleagues that were in the Nigerian collaborative together, and we were able to put our heads together and think we had very good outcomes, at least for the local government I worked in. Thank you very much.
Thank you very much indeed, Gregory. Let me ask you, though, when you say very good outcomes, what actually changed? Was it vaccination coverage? What were you looking at in terms of outcomes? And was it coverage or was it something else?
Yeah, the coverage was one of it. Number one was coverage. Number two was that we were able to reach more children that were recorded as having not received the vaccine before.
Yep.
And number three was the fact that the wastage rate was not as high as it ought to be. And number four, that we were able to tackle the situation in which there were multiple outbreaks. I think we were able to, when I say good outcomes, I mean that we were able to tackle the situation whereby there were multiple issues to be addressed simultaneously using the same ad hoc staff, and they performed very well.
Okay.
Thank you very much.
Gregory, I'm not quite done. So what makes you think that what you did in the collaborative somehow contributed to this positive outcome? Because obviously, as a retired professional, you're bringing yourself a lot of experience as an individual. If there was a response organized and there were specific dedicated additional resources, how do you know, what makes you think that the collaborative actually had anything to do with it?
Well, the number one, as I said, there were colleagues, particularly the local government facilitators that I left behind. I was pleased to hear that they participated in the collaborative. And whatever step I wanted to take, they were almost ahead of me to say, sir, we have learned this and we are going to apply it. So I think that is one of the results, one of those areas that I feel that it was contributed to the good outcomes, plus the knowledge I was able to bring to the situation. I think I could say those outcomes I listed were far better than I would have expected, considering the chaotic situation we were in. Thank you very much.
Thank you very much indeed, Gregory Agogo. We're talking about 4 months on after the launch of the Immunization Collaborative, so more than 4,000 health professionals in Nigeria, all 30 states, over 300 local government areas came together to analyze the root causes of their local immunization challenges. We're now 4 months on, so we're asking not just what root cause did you find, we're also asking what progress have you made in 4 months. And we have a response from Fanny. Unfortunately, she's not able to speak to us due to connectivity problems, which are right now quite significant in West and I believe also Central Africa. The progress, so Fanny says, the progress made thus far is that we have established a working relationship with the community leaders, and they have agreed to engage their political leaders for the provision of alternative power source to the PHC, to the primary healthcare center in Olyogo and Dokwa, West LGA of Delta State. So what I would be curious about, Fanny, of course, I'm so sorry that you're not able to speak to us, would be how do you know that your participation in the collective has anything to do with the progress that you have made, other than the conjunction of dates? Really talking about how can you attribute with any confidence that what you did in the collaborative actually helped contribute to this progress? We've heard from from Nigerian members of the collaborative. I want to turn now to Mario Chatsi Damianos. I think you have us on two speakers because I can hear myself in the background. You'll probably want to mute that. But Mario, can you tell us, did you know about the collaborative before Teach to Reach 11? And what would be your questions, comments, reflections for Nigerian colleagues who've been leading this collaborative since July 2024?
Thank you for the opportunity. Indeed, I wasn't aware of the Teach for It incentive and initiative, and my first relation to it was back 4 months ago, where my interest in Nigeria was generated for me participating into the exercise of understanding why the people are not being immunized in Nigeria to the level of the volume that many of the frontliners expected. And after engaging with the methodology and asking the whys over and over and over again, we realized that in so many cases, the problem lies with the cultural beliefs and barriers that are there through the local leaders, either if they are spiritual or political leaders. And a lot has to do with insecurity as well, based on the fear and the lack of knowledge about immunization. To this end, as already shared with the network, we have been 4 months into collaborating with local agents and local organizations, and I'm proud to say that we have now devised an intervention of acquiring data around the cultural beliefs, and we have devised a collaboration with counterparts from the US, the EU, Nigeria, as well as new partners that we're looking into Asia to assist us. And having identified also the cost that we will be needing, we are ready to reach out to organizations as we did to the past 4 months to support us for the kickoff meeting in ways that we can invite as many of the collaborative members to join us and share this initiative with the rest of the immunization force in Nigeria.
Thank you, Mario. I understand better. So yes, we think of ourselves as gate openers rather than gatekeepers. Has your organization considered joining the collaborative as a partner of the collaborative in the same way that you can become a partner for Teach to Reach?
Yeah, indeed, we are already evaluating the related documentation. So we are thinking of how we can join the collaborative as an organization, an official organization, to assist to the depth that we can offer insights based on data analysis and from our platform. Thank you.
All right. Thank you very much indeed. Okay, Charlotte, let's go back now. And again, a reminder of what kind of countrywide and sector-wide engagement participants from many different sectors. We had there were pharmacists organizations, for example. There's also a very impressive group of women health leaders who joined, who are amongst the 4,000 health professionals. And then you can see not only health professionals as individuals, countrywide and sector-wide, but also a sector-wide representation of organizations from local, state, and federal levels, local government agencies, civil society organizations, pre-service training institutions, all joined the collaborative. So the figures after 3 weeks: 628 organizations, 400 root cause analyses, and now, today, we're taking stock of what difference this has made. First of all, for members of the collaborative, what root cause did you find and what progress have you made? Charlotte, who shall we hear from next?
Rather, we have Janice. Emmanuel's mic is unmuted already.
Okay. Good afternoon to you all. I'm Janice Lemon by name, Inas by professions, and a public health practitioner. Previously, I worked with the government as the head of one of the institutions, General Hospital, and I moved working with the other INGO and like INC, MSF, and also the Integrated Health Project in USAID. That cover all aspects of health, including immunizations. So what I learned, that's in building the capacity that make difference in my, especially I supported the immunization services in my area, particularly in Latin Mapara. We reach our target and we make the coverage, even though we face a lot of challenges, and that challenge we have built up for the past 3 months. We learned that in Zamfara, especially in my area, we have been updated our records. So that lack of updating records create a gap where our area is in red. But with my intervention and the knowledge I get in Teach to Reach, So I intervene and I collaborate with the M&E officer so that he will be able to update the tracker so that that red line on immunizations will be removed. And also during that immunization period, what I learned, we learned that there is one particular community that rejected our folio. So, but because of religious perspective, so in that case, with my intervention and other health workers, especially the health educator and the director of health and the team composition of team, we reach out to the religious leader that that particular community attach themselves with him. Then we sat down, we make a dialogue to the extent that they accepted the folio and understand what it means. So what we did, what make difference is that I make what we call multi-sectoral collaboration. In that multi-sectoral collaboration, I collaborate with the traditional leaders, religious leaders, and other stakeholders. And also, I did what we call community engagement. In that community engagement is there where I engage all those peoples. And also, there's what we did as a team, as a tailored approach. In that tailored approach, despite the challenge of insecurity, but we see how we are going to face the community that are highly insecure, and we reach out to those zero dose and the missed dose children, and also we tackle the logistic challenges and also the misinformations. That misinformation is there. We have what we call did mobile immunization team. That mobile immunization team, they move from this particular community to the other. And it is that, as I said, data driving and initially in my communications. So that data, that real data we have at hand, it helps us in monitoring and assessing the issue of immunizations in that particular community. And also there's what we call mapping and developing of community health volunteer. That community health volunteer helps us in reaching out different families and different households in the community so that all the children are fully immunized and we don't to see a missed dose or zero dose child. So all those things we did demonstrated a tailored improvement in our immunization in the last 4 months. So this I can say this make a difference, and it's as a result of my interactions with the Teach to Reach that I can be able to work and make a difference in supporting immunization activity in my area. That's all.
Thank you very much, Tijani Suleiman. We heard just a few stories from this massive initiative and mobilization by Nigerian health professionals across the country. This is the Nigeria Immunization Collaborative, part of the Movement for Immunization Agenda 2030, a global movement launched in 2021 on the 7th of March, 2022. Teach to Reach has been one of the places, one of the times when we've heard from leaders of this movement from many, many different countries. We're now going to close this session in order to prepare for the next one. This was the Nigeria Immunization Collaborative, but if you go back, and I hope that for those of you who are watching on YouTube, Twitter, X, LinkedIn, Facebook, wherever you may be, please do what you try again. Give it another go to try to join the next session that I'll show you how it works. Once you make it to the lobby, you need to, we need to cancel the reservations. You don't need to do that if you've done it, but I just want to show you how it works. You need to reserve a spot. And for example, the session that is going to start in 13 minutes is about health workers uniting to end malaria. It's actually the sneak preview for a special Teach to Reach event that we'll be holding on Tuesday with the Partnership to End Malaria, RBM. You do need to reserve a spot. Otherwise, you will not be able to join this session. So that's really the key, is when you're in the lobby, you can watch but you cannot actually participate. So we very much encourage you to join the session, and you do that by, first of all, reserving your spot. So that's basically saving you a seat. And the same after that, we'll be going to Grand Challenges Canada to discuss and explore and share experience on climate, health, risks, and barriers. So that is what is coming next for Teach to Reach 11. We're delighted to bring together to hear from the Nigeria Immunization Collaborative, and look forward to hearing more of the impact that you're making by connecting together through the collaborative. Once again, thank you and take care.